Hey, so hello everyone. Before we start today, I want to acknowledge with respect the Indigenous peoples and communities whose historical relationships with the land continue to this day and on whose traditional territories our work takes place. While we meet today on a virtual platform, we can take a moment to acknowledge the importance of these lands, which we each call home. My name is Autumn Sipis. I am a project manager for the Canadian Coalition for Green Healthcare, and on behalf of the Coalition, the Canadian Association of Nurses for the Environment, and the Ontario Nurses for the Environment, I would like to welcome you to our fifth and final Nursing Week event, From Practice to Impact: Nurses Advocating for Sustainable Change. As I said, this is our last event of the week. We've had four other amazing events every other day since Monday, and all of these events have been recorded and will be sent to registrants at the end of the day today once I get this one uploaded to our YouTube channel. They will all also be available on our website, and I'll be sending out lots of great resources that have come up through the week as well in that email, so keep an eye out for that this afternoon. Throughout the event, please use the chat function for any technical issues you may be experiencing. Use the Q&A function for any questions you have regarding the presentation, and our panelists will be answering questions at the end of the event today. We have three amazing presenters with us this morning. We have June Kaminski, Caitlin North, and Cailin Doyle. So starting us off will be June Kaminski, who has a Bachelor's of Science and a Master's of Science in Nursing from the University of British Columbia. June is the project coordinator for the Coalition's Preparing Canada's Healthcare Buildings for Net Zero project. And June has also volunteered with the Canadian Association of Nurses for the Environment for the last 17 years in a variety 16 years, it says, probably almost 17 years, in a variety of roles, and worked in nursing education, writing, and research for 37 years. And we have Katie North, who is a registered nurse based in Winnipeg, Manitoba. She graduated from the RN program at Université St. Boniface in 2011 and completed her Bachelor of Nursing in 2012 at the University of Ottawa. In 2021, she returned to school and completed a Master of Nursing with a focus on healthcare leadership and a Graduate Studies degree in environmental sustainability in 2023. Katie is the manager of health services for medicine at St. Boniface Hospital in Winnipeg since 2022. She also serves on a number of committees. It's a long list, including a Sustainability Development Committee for USB, CANE as a Sustainability Director, the Manitoba Nurses for Health and the Environment Collective, Capital Planning Advisor for the Canadian Coalition of Green Healthcare, the Association of Regulated Nurses of Manitoba Governance Committee, and the St. Boniface Hospital Environmental Sustainability Chair. And last but not least, Cailin Doyle graduated from the University of Toronto with her MN-NP in 2021, prior to which she had been an RN since 2003. She currently works for the Department of National Defence as a civilian primary care nurse practitioner for Canadian Armed Forces members. She has long held an interest in environmental issues, more recently focusing on the intersection between the effects of climate change and the social determinants of health, as well as efforts to increase sustainability in the healthcare system. She is a member of ONE-IIOE's Ontario Nurses for the Environment executive team and has been their newsletter editor for the past 2 years. I'm now going to hand things off to June to kick off the presentations today.
Thank you, Autumn. I'm just going to open up my PowerPoint. So hello, everybody. I'm here today to talk to you about a resource that the Coalition has been working on, and I've had the pleasure of spearheading. Basically, it's called a Sustainable Green Inhaler Guide for Nurses. Now, this is part of our deliverables for our Preparing Canada's Healthcare Buildings for Net Zero project. And the logo that you can see on the right shows the four areas that this project's focusing on. So we've got NICS and nitrous, green teams is a little green part, the orange part is the green inhalers, and the purple part is low carbon energy in healthcare buildings. So this is obviously part of the orange one. And our goal is basically to help healthcare workers identify opportunities to replace MDIs with low carbon inhalers where suitable, and to develop an implementation plan. So the specific resource will be made for nurses. this is part of a two-prong deliverable approach that we have for nurses. The first one is an article that has been written and accepted by the Canadian Nurse, and they tell me it'll be coming out May, June. So watch for that. It's coming soon. And also this guide is still in the development stage, and we're just about at the review stage. So we will be looking for nurses who want to volunteer to review. So if you're interested, please send me an email, and I'll put my email in the chat, and it'll also be on the final slide. So basically, this is a clinical guide for nurses to optimize respiratory care while actively reducing greenhouse gas emissions of inhaled therapies. So studies show that there is a knowledge gap, and this is across healthcare professionals, not just nurses. 90% of respondents often routinely assess inhaler technique. 40% did not know the difference between an MDI or a DPI. They didn't ask them about an SMI. And 36% had received some training, or it was really informal and it's kind of outdated. So basically the consensus was 97% of this particular study. Surveyed professionals agreed that formal inhaler technique assessment training would really help. Now, the big issue with inhalers is the particular group, which is meter-dosed inhalers or MDIs, have a lot of emissions that are not good for our environment. So 98% of the emissions that come from inhalers are from MDIs. And in one study that was done in British Columbia, they found that inhalers accounted for 21.8% of their health facilities' total emissions, which is about equivalent to driving a gas-powered car for thousands of miles. And by switching to a DPI or an SMI, you could save a lot of kilograms of CO2 equivalents per year. This just breaks it down a little bit more for you. That MDI, as you can see, the cloud is much, much bigger than for SMIs, DPIs. MDIs have a range of 10 to 28 kilograms of CO2 equivalents per inhaler because of the hydrofluorocarbons that are used to propel the medication to the client. SMIs are about 0.8 kilograms. DPIs are between 0.5 to 1 kilogram. So you can see there's quite a big difference. So switching 1 year, as I said before, of one adult patient's use of inhalers could prevent a lot of a reduction of emissions. So about a 78 reduction in their annual inhaler emissions. I'm not going to go into too much detail with these. We are on a time limit, but just to give you this will be in the guide, and it can show you exactly what the anatomy of the three inhalers looks like. Kind of breaks it down, how they dispel the medication, etc. I think everybody's familiar with the MDIs. They're used widely, etc. One thing that we can do to make sure that they're used properly and no medication is wasted, etc., is to encourage spacer use when it's convenient if the person wants to stick with an MDI. And also just to point out that there is research going on to try to make next generation propellants so that there's a reduction in the HFCs that are being emitted, etc. But that takes about 10 years. I'm just trying to open my timer here. It can take up to 10 years, so that's in the mix, but it's really not helping anybody right now. This is another slide that will be in the guide, anatomy of a DPI or a dry powder inhaler, how they work. The engine of this particular type of inhaler is the actual patient. There's no chemical propellant, there's no mechanical propellant. The device relies entirely on the person's own inspiratory flow. So as you can see, for some patients, this might limit their ability to use the DPI. It uses turbulent energy, and then it dispels the microscopic drug particles, which are often bound to larger carrier particles like lactose. And there are some variations that are lactose-free, etc., so that's not an issue for some people that have lactose intolerance. And it's an ultimate low-carbon alternative. As I said before, it's 0.05 to 1 kilograms of CO2 equivalent. So this is a good choice as if the person's able to use it. And then the soft mist inhalers, they have a mechanical spring in it, which helps to replace the chemical. It replaces the chemical propellant by turning the base. Turning the base compresses the spring, which stores the mechanical energy and then releases the medicine in a soft mist. So it's like a soft cloud that comes out. So this also has really low carbon intensity as well as it's easier to use. But there are more limited varieties to choose from at this point. So just looking again at three different types of inhalers. Again, this will be in the guide. So I'm going to kind of rush through these slides that have lots of detail, etc., just to let you know it's going to be there for you. But just quickly, let's look at the mechanics. So the MDI uses the hydrofluorocarbon propellant. DPI is propellant free, but it relies on the person, and soft mist uses mechanical energy, which produces a slow aerosol cloud. So the inhalations that are needed for those for an MDI is slow and deep. For a DPI, it's rapid and forceful. And for an SMI, it's passive, just normal. And then coordination is another consideration. For an MDI, it requires quite high coordination to be able, unless it's paired with a spacer. For a DPI, it's minimal coordination because it's breath actuated, so they'll just have to hold it. SMI as well is low coordination, and we've already looked at the environmental impact, but that's there again. So taking a planetary health lens of working with green inhalers then relies on four different steps. One is the accurate diagnosis, which is not usually in the purvey of a nurse, unless they're a nurse practitioner, but they can certainly help with inform the prescriber if they notice things that maybe suggest that they don't really have asthma, or they don't really have SOPD or COPD, etc. So validating the actual need is usually done by the prescriber. But device advocacy is a huge part of nursing. So advocating to match the patient with the lowest emission device that would serve them. Technique definitely is part of nurses' purvey, making sure that that technique is correct. And then life cycles disposal, we certainly be encouraging clients to dispose of their inhalers properly. So the greenest inhaler is the one a patient genuinely needs, uses flawlessly, and recycles safely. So if we look at this from a life cycle perspective, all inhalers are pretty high intensity at the manufacturing level, the dispensing level, and the end of life level. It's at the patient use level that we really see the difference. So the DPIs and the SMI footprints are much lower at that stage. But with some people, MDIs are necessary. They're not going to switch. So DPIs and SMIs are not for everyone. Sometimes children, people with severe COPD, maybe people with arthritis or low dexterity, etc., those with insufficient inspiratory flow, or maybe their plan doesn't cover the finance issues part, etc. When it's required, it's suggested to use a spacer, perhaps prescribe Aramir, which is a lower carbon footprint MDI, and then encourage recycling, etc. So again, optimizing patient care, we want to go look at validation of diagnosis, assessment of the suitability, and I really need to emphasize the shared decision-making, that the patient needs to be aware of what's happening, what are the choices, and be part of that decision, educating for proper technique and teach back, and end-of-life recycling and disposal. I'm just going to quickly just show you this, that oftentimes some studies have shown that people with asthma and COPD are often misdiagnosed. So there should be some spirometry testing, etc., to make sure that that is an accurate one, but that's not in the purvey of nursing, just so that you're aware of this. So you need both objective testing and then continuous reassessment to make sure that it's still serving their needs, whatever inhaler they're using and so forth. Here's a little tree. Again, I'm just going to quickly go through this. If the patient's currently stable on a high global warming potential MDI, you could ask is, does the patient have adequate inspiratory flow? If no, maybe keep them on the MDI and but encourage a spacer. Do they have sufficient manual dexterity? If no, again, you might have to keep them on MDI or switch them to an SMI. Are they cognitively able to learn a new technique? Is the green alternative covered by their drug plan, etc.? So there's different stages that you could advocate for a switch with the prescriber. Again, things that you need to look at as a whole person assessment is their cognition, their age, their lung expiratory flow. That's really an important part, especially for DPIs, and their hand dexterity and so forth. So all of those things need to be assessed and then combined with the shared decision making. So it's really important, I just want to mention that again, and we all know that from as nurses, that we need to discuss things with our clients, make sure that they're on board and so forth. So they need to know about the device functions, which we just kind of looked at. They need to know about the environmental impact, maybe the drug combination, whether it's meeting their needs, etc., and then the other patient factors that I've already talked about. So going into the teaching part, teach back method, which I'm sure many of us are familiar with and use a lot, is a good way to do this. So demonstrating proper technique, getting them to teach it back to you, and then reassessing the technique and maybe helping them along if there's something that needs to be corrected. So these next four slides are quite information intensive. Again, these will be in the guide, so you don't need to learn them now, but just quickly go through that there's certain errors that nurses can help to correct. And for instance, not shaking the MDI or not using a spacer can cause more planetary harm, etc. So I'm not going to spend too much time on these, just to let you know that they're there. So there is one on MDI teaching, DPI teaching, and SMI teaching. And these are all within the guide so that you can access them. And then going through the teach back loop again, executing the teaching, evaluating or demonstrating, executing, evaluate, correct, and reassess. So this is just a reminder of that loop. Also, this too will be included. So looking at the different steps, setting it up, doing the actuation, doing the inhalation, and doing the hold, etc. So it kind of distinguishes these between the different types of inhalers. So again, just that life cycle where we fit in, we can advocate for DPIs and SMIs with the prescriber. We can teach back to make sure that their technique is flawless, and we can help prevent landfill disposal by encouraging them to return their inhalers to pharmacies that will accept them and recycle them. So we're primary professionals capable of breaking the chain of emissions at multiple points in this journey. So the last part is end of life, safe disposals and recycling. It is not safe to dispose of inhalers in the garbage at home, etc. There is a huge amount of waste, both the plastic as well as the MDIs. So if they're thrown into standard waste, they end up in landfills where the HFC propellants can slowly escape into the atmosphere. So it continues to do its damage even after it's thrown out. So educate people to return all used or expired inhalers to the pharmacy. And this is just a little visual of how that can just goes out into the atmosphere, etc. And there is a QR code here that you can scan there. The Health Product Stewardship Association is making a database. They have one that's ongoing. They keep adding pharmacies that participate in safe disposal. So you can scan that to see if there's one close by that you could recommend to your patients. Some pharmacies will take it back, etc. So that by keeping them out of the landfill is a strong nursing task. So just to sum up, the synthesis by inhaler optimization is both a clinical and an ethical imperative. By diagnosing accurately, assessing thoughtfully, teaching effectively, and promoting safe disposal, we can help protect both our clients and the collective atmosphere. And this last slide is just a little checklist again. Verify the underlying diagnosis, assess their flow, dexterity, and cognition, discuss the environmental impact, make sure you have patient consent and verify their financial access, validate proper technique, and encourage proper disposal. And if you would like to get involved, this is the link or the QR code for our project website that's on the coalition site. We also have a mailing list that you can access. And then my email and Autumn, who introduced us, email is at the bottom here. And that's it for me. I'm going to pass it on to Katie.
Great, thank you so much. Okay, thank you. Hello, everyone. My name is Katie North. I am a PhD candidate with the University of Saskatchewan, and I'm joining you today from Winnipeg, Manitoba. I am happy to be here for Nurses Week and talk about my involvement with environmental sustainability and advocacy for green projects within tertiary care in Canada. And I want to highlight more of a high-level overview for you all today, the impact that healthcare has on our climate and the impacts that are felt globally from what we are doing here in North America in terms of healthcare and how that is impacting people in other countries. And then I want to briefly go over some research that I have been doing for my PhD, where we're trying to target ways that we can eliminate unnecessary plastic waste, specifically in the operating room. So firstly, I'm sure you're all aware that environmental sustainability and green technology and green policy and procedures have been on the uptake in terms of public interest over the last couple of decades. There's a lot more groups like what we're seeing here today, representatives from CANE, from the Canadian Coalition, and many others that are coming together to advocate for the environment and for planetary health. And lots of linkages that are being made in terms of academic research relating overall public health with planetary health. And that is an emerging and currently developing field in terms of academia and research as well. So many different sorts of organizations and corporations are starting to develop environmental sustainability and aspects of that into their business models. We're seeing corporate values, strategic priorities, and other service administration levels within companies in both the business and private sectors adopting environmental sustainability, which is a very positive thing for us who are all interested in seeing big changes, although it might not be happening quite as fast as we want it to. A lot of these improvements to policy procedures and strategic priorities in terms of green tech and promoting green projects are prompted by that research piece that has been done and the connections that we're making between human health outcomes, the environmental crisis, and our activities as human beings causing this cascade of effects. So my hope for you today through this presentation is that you'll get a better understanding of the linkages between our activities specific to healthcare and how that's impacting the population. But then also I want to look at some real-time solutions that we as nurses can promote within our organizations, especially in the area of tertiary care in North America and here in Canada in particular. So, a little bit of background. I know you're all well versed in what the global climate crisis is, but this is a man-made climate emergency that we are seeing. And the image here of the polar bears really resonates with me as I grew up in Manitoba, and our province is home to approximately 963 polar bears who cross through Churchill, Manitoba every year on their journey onto the ice in the Hudson Bay. So seeing the impacts, this is not just something that is impacting human populations, but it is felt by all different sorts of species across the planet. And the main contributors to the global climate crisis right now, it might not be as evident that plastic pollution is the number one contributor to our global climate crisis and declining health, especially for marine animals and land animals. Fossil fuels is also a major contributor in terms of the greenhouse gas effect that we see and the rising temperatures. And that is pretty well studied and acknowledged throughout the academic circles that this is a major concern for climate crisis, as well as deforestation. We're taking down forests, which will ultimately be the way to counteract CO2 emissions to some degree. And that is just contributing and making the issue even more exacerbated. So healthcare and climate have a unique and twofold relationship. Um, Climate change is both caused by human activities that come from the healthcare sector, as well as the other sectors. Um, but also, the healthcare sector is responsible for caring for people who then have a health crisis due to climate change. So, we are also carrying and bearing the burden of the effects of climate change while subsequently contributing to the problem at the same time. So it's a complex relationship, and we as healthcare workers need to evaluate and understand that our actions are actually worsening the climate crisis in some ways and find ways to mitigate our contributions so that the patient population and the problems that we are going to encounter in healthcare are not directly related to our activities to sustain healthy populations. So some effects that can be felt within human populations from climate change include an uptake in viruses, food and water contamination, especially when populations are displaced due to major climate events. That can also lead to political conflict and an increase in disease presentation due to people migrating and being in close quarters, and unstable natural resource availability. Here in North America, we are less likely to feel the effects of climate change at this time, although as things progress, the World Health Organization does anticipate an additional 250,000 lives lost annually due to climate change by 2050, and we may start feeling the impacts more and more here in North America. But generally, developing countries, those with poorer and unstable political or governments generally feel the bulk of the climate change impacts on their populations. So healthcare is very closely um, related to the climate crisis, but in particular, the surgical field is an area where we need to examine where we can make changes to reduce the amount of plastic that is being created and put into the atmosphere um, or into the landfills. Surgical departments, on average, are responsible for approximately 33% of all hospital waste. So it is a very high waste area, high waste clinical area in particular, that needs to be targeted with different approaches to reduce the amount of plastic that we are seeing. Sterilized instruments, single-use equipments, and personal protective equipment are major contributors of plastic waste in the operating rooms and other surgical areas pre and post-op. Unfortunately, a lot of the methods, policies, procedures, techniques that we use in surgery are not environmentally sustainable. It requires a large amount of plastic in order to keep instruments contained and maintain that sterility, and also offer protection to the staff members in forms of PPE and the patients that are there for surgical procedures. There are some solutions in order to reduce plastic waste that we're seeing in surgical areas, transitioning to products that are bioplastics. So bioplastics are an alternative form of plastic that could be used for packaging in some situations that is 100% biodegradable. And in order for a plastic to qualify as a bioplastic, it needs to be able to decompose within approximately 30 days in an industrial landfill with no additional chemical requirements in order to provoke that process. So, depending on which region you live in, there is different legislation for that term, but generally the benchmark is about 30 days for that decomposition process. And that is just due to the natural microbes that are found in an industrial landfill. Plastic recycling is also an option. Unfortunately, a lot of the wraps and bags that instruments come in for the OR are not eligible for recyclability, but that would vary based on your municipality. And depending which city you're working in and where your hospital is located, if those recycling facilities exist that can process those specific types of plastic. So this would require some significant coordination between municipal processing and the hospitals in order to determine what the needs are and what the capacity is for that region and that city to actually begin the uptake and the process of recycling the plastics that are being used in the surgical areas. Workplace culture is also another barrier. Replacing existing plastics with alternatives. We know that there will be a cost associated with that. Perhaps also procedural changes that are required in order for these changes to be made, as well as sterilization guidelines for the specific types of plastic that are being used. So taking that into consideration, the surgical area really could use a revamp of its processes in order to decrease the amount of plastic pollution coming out of the OR. So some solutions, like I mentioned, the bioplastics are a potential option. This is my preferred option in a lot of ways, especially for items that can be autoclaved and that can be covered with a biodegradable plastic after they are sterilized and maintain that sterility because there's no petrochemicals. So as the bioplastics are decomposing in the landfill, they're not leaching petrochemicals into the landfills, and there's a minimal impact on the environment. Other items that we see frequently in the hospital as well in terms of disposable cutlery, cups and wrappers, garbage bags, other items that are used day to day for inpatient areas could potentially be replaced with a biodegradable version as well. Um, and all of these solutions and specific approaches to reducing plastic waste can be piggybacked on other projects. So composting food waste within an organization, along with biodegradable plastics, is a great way to reduce the CO2 emissions that are being generated from landfill and remove some of those items from industrial landfills. Reevaluating the supply chain and going with vendors who offer green or environmentally friendly products. Um, Speaking to your local government about legislating for better products, requiring that healthcare organizations make changes to the products that they are using. Once that demand is in place, the suppliers within Canada will produce in order to respond to the demand. But getting traction the other way around has not been largely successful in the studies that I have read here in Canada. So having a workplace champion, people who are in the field of nursing, who are on all of these environmental committees, is essential in order to get the ball rolling in some of these out of scope projects. Specifically for my study, I'm recognizing that there are some barriers specific to the culture of the organization, and a lot of the procedures that need to be done in order to make these changes within healthcare require connections with local government and the municipality and things like that that are external to the site. So I've opted to do an ethnographic study of a tertiary care facility to examine how their culture is influencing the green projects that are being implemented within the site for either better or for worse. So I'm still in the early phases of this study, um, and we are assessing what a nurse-led environmental model for procedural changes would look like, how that would be well received within the site, and what are some of the potential barriers in relation to that. Through semi-structured interviews, some of the things that I'm recognizing in terms of healthcare waste and making some of these changes to the operating room, integrating biodegradable plastics. The main cultural barrier is finances. Everyone is hesitant in the Canadian healthcare system to go into a deficit in order to fund any types of changes, despite the bulk of research that has already been done demonstrating the effects of climate change on health and even estimating the long-term costs that we will incur as a healthcare system down the line from climate-related illness. There is still a lack of motivation and a lack of willingness for healthcare organizations to step forward and put the money in as an investment now in these green products and to change their policy and procedures. The other barrier is that the companies that are creating healthcare products that we use as vendors here in Canada are not offering green alternatives, or they are not offering financially competitive green products because there is not a sufficient demand at this point. So understanding the root cause is my main objective, determining how healthcare organizations put emphasis on long-term or on current finances over long-term potential healthcare objectives for climate is something that I want to examine in further detail. And then ultimately determine what can be done in order to shift the focus and shift the culture so that we are more readily accepting of some of these changes, like the integration of biodegradable plastic, as studies have been done that show that this is a feasible option in a lot of operating room facilities. I'm hoping that this study also will launch some future projects within tertiary care site, like on-site composting and reduced reliance on fossil fuels. Like we just saw in the previous presentation, the Nix the Nitrous campaign was getting a lot of traction in Canada, and so I'm happy that we also participated in that challenge in the surgical department that I have been studying, and they were able to reduce their CO2 emissions through changing of anesthetic gases. So when combining these projects, I'm hoping that that will influence the culture in the long term to a more adaptable and ready culture to take on some of these challenges and implement some changes that are much needed within the operating room in tertiary care. So in conclusion, I just want to highlight for you all that climate change really is a global emergency and that we play a role in contributing to the climate crisis, and we are also going to have to absorb and care for the patients that are negatively impacted by climate change. And it would really make a lot of sense to implement these changes now so that we can ensure long-term health benefits for our patient populations and reduce CO2 emissions as well as the amount of plastics that are being produced in the healthcare sector. More research is needed, more advocates are needed. So if you are a champion and passionate about healthcare, please make yourself known to your organization and reach out to any of the presenters that are here today or our organizations to get in touch and find out how you can advocate for some of these procedures. Thank you. And I believe we'll pass this along now to Cailin.
Okay, can everyone see my screen?
Can see your screen. It's not in presenter view though.
Yes, this is what I did before, didn't I? How about now?
Still in the edit. Oh, there you go. Perfect.
Okay, and I'm just trying to turn on my camera, which, there we go. All right, there I am. Okay, so thank you to Katie and June so far for the presentations. So my perspective really will be from the primary care side of things and from the prescriber side of things in terms of how to make our healthcare settings more sustainable. So I'm going to focus on the principles of sustainable healthcare and maybe if we have time, get into some of the social tipping interventions and share with you some of the changes that I'm making in my own practice. So I won't get into this. I just really like this visual of the impacts of climate change on human health. Likewise, the impacts on our patients and then the risks to us as healthcare providers and the risk to the healthcare systems. So these are all many reasons that we should be involved. I know I'm preaching to the choir. You're all here. You all care. One of the most important things is that we see our patients holistically. So we know that what's good for our patients is good for the planet, and vice versa. So that's a key message that I'd like to share with you today. Um, and we need to be involved as well because, like it or not, we are part of the problem, as Katie went over, just by virtue of being part of the healthcare sector, because we know that the healthcare sector is responsible for nearly 5% of greenhouse gases. And June covered as well, like this life cycle idea of medications and medical supplies. So it's not just what we see at the end of the line with the disposal of PPE and other waste. It's really from that material extraction and processing and distribution. So in primary care, we can see that, pharmaceuticals, especially when we combine these with the MDIs, as June covered, account for a huge proportion of greenhouse gas emissions. So we know we need to be involved. How do we do this? Well, there's kind of two big umbrella strategies. Adaptation is really looking at the downstream kind of actions that we can take. And so many of us are likely doing this now, whether we realize it or not. Protecting our patients, especially our most vulnerable ones to climate change impacts. We are doing patient education. We are doing disaster preparedness. Mitigation, which is really what we're talking about today, is some of the upstream actions looking at the root causes of our impact in the healthcare sector on climate change and the climate crisis and what we can do about that. So I love this slide because it shows that mitigation actions really do provide in almost every case healthcare co-benefits. Um, all right, so I love this resource. It's my all-time favorite resource. The author is Dr. Ilona Hale. It's published through Cascades, and it's the Sustainable Primary Healthcare Toolkit. So the four main principles of sustainable healthcare: reducing unnecessary care, empowering patients, health promotion, and environmental alternatives. So when we're talking about reducing unnecessary care, we know that overdiagnosis is a huge problem. This is labeling a patient with an abnormal condition that otherwise wouldn't have caused any harm. Um, and we know that unnecessary care is actually, about 30% of investigations and treatment are unnecessary. And they often cause harm to the patient, not to mention the effects on the healthcare system in terms of wasted money, increased workloads for staff, and they have a huge environmental impact. So there is this idea about de-diagnosing, which is interesting if you'd like to look into that further. Medications are, as we saw from the previous pie chart, really big factor in greenhouse gases in primary care, and actually 25% of the healthcare emissions overall in Canada. So it's been said in the literature that pharmaceutical manufacturing is more emission intensive than automotive manufacturing, if you can believe it. So I mean, the most environmentally friendly thing that we can do is to avoid prescriptions if they're not needed. So one of the easiest ways to do this, and most of us are aware of this too, and patients are too, I find, is the antibiotic stewardship and really not prescribing when it's likely to be a viral infection. I just want to share with you. I like this resource. It's not something that I generally give out to patients, but it's a framework that I use to explain to patients, especially in our urgent care clinic or same day clinic where we see a lot of respiratory infections, why I think it's a viral infection based on their symptoms and based on their assessment. And I try to do a lot of teaching around why they don't need any medication, or just, Tylenol, etc., the old school rest, time, fluids. Most people are usually okay with this. I do find that it gets a little bit more, there's a bit more pressure for meds when, we have like a post-viral cough getting into like 3 or 4 weeks and people are antsy for treatment. But okay, so there's evidence lately that shorter courses of antibiotics, when they're needed, are actually just as effective as the longer courses we used to prescribe, especially for sinusitis, for example, in the new bugs and drugs guideline. A 5-day course is generally just as effective as the previous 10-day course we used to give. Deprescribing is really important. In my job right now with the military, we don't see a ton of polypharmacy, but one medication I really do try to focus on to deprescribe if the patient's willing to do it are PPIs. I find that people are on these, months, sometimes years without ever a trial of getting off of them. So I always try to make sure that, there's not like a Barrett's esophagus or some kind of reason or a scope that's been done that suggests that they need to be on these indefinitely. And, a lot of people are successful coming off of these. And I find that most people are quite happy to be involved in, de-prescribing and they're on board with this. It's important to remember that non-prescription medications also have an environmental impact. This is another resource that I just wanted to quickly share. I love this. I just just came across this. So this is the OTC Green Quick Guide. These are just some examples. So PPIs, again, they do have a moderate carbon impact, as we can see. So if there's any, we need more incentive to deprescribe them or try tapering off. Here it is. Tylenol has a lower impact, for example, than ibuprofen. So that's a great resource. So I'm just going back and forth here. When we're talking about medical imaging, we know that, sorry, back to labs, actually. Just wanted to cover this quickly. So labs use 10 times more energy and 4 times more water than offices. They produce billions of pounds of toxic waste each year. One of the facts that I came across that really triggered me to be more mindful of my ordering of labs was that each complete blood count is equivalent to driving a standard car zero point 0.8 kilometers. And when we think about in Canada, there's over 1 million lab tests each day. This really does add up. A lot of them are not clinically indicated. So some of the changes that I've been doing in my practice, and I follow Choosing Wisely recommendations, and they have some amazing resources. But I no longer do kind of standard orders like across the board. So, for example, I used to order, complete blood counts on everyone, renal panels, liver enzymes, electrolytes, for patients who were coming in, say, for just like a 2 or 5 year checkup for the military requirements. And then you kind of get into this rabbit hole sometimes of chasing these normal limits. So getting people to come back, more and more testing. And we do know that 1 in 20 lab tests of healthy people they're going to fall outside of that normal reference range. So I really try to become more conscientious about which lab tests I order. and really base that around like family history, if the patient's symptomatic, etc. I no longer, for the most part, order full panels, like especially with liver enzymes, for example. Usually, and this is a choosing wisely recommendation too, ALT and ALP are fine to begin with. So that saves on a like, I no longer do like GGT and bilirubin and all of those ones. One of the recommendations to avoid overuse of lab testing is to order tests to confirm a diagnosis and not to look for one. This is really tricky. It is something that I'm working on, but it's very difficult when patients come to you with vague symptoms like fatigue. There's this compulsion to like check every differential and really overorder. So trying to be more mindful about that. Hormone testing is a big one. I find that this is what patients probably ask me the most. Young, healthy males, many of them want to know their testosterone levels. And then middle-aged women really ask a lot about perimenopause and hormone testing. The great thing about evidence now is that we don't need hormone testing to um, to diagnose perimenopause or to guide treatment. So once patients realize that and they're, being validated and we can start treatment if it's indicated, they're very happy and they're okay with not doing the hormone testing, which are notoriously inaccurate. Okay, so imaging, I also get a lot of pressure from patients for this, probably more so than anything. Uh, Many people want imaging of their back for chronic pain. Um, and, a CT scanner for a year was comparable to five four-person households in terms of emissions, and one MRI scanner was comparable to 26 four-person households. So we know that overuse of imaging is a real drain on the system, and it's harmful to patients if it's not indicated because we come across these incidentalomas a lot where we're looking for something, we find something else, and then that issue was never the problem, but then we go get into this interval checking and more and more and more testing, and it causes a lot of anxiety for the patients, among other negative effects. So, with overuse of medical imaging, we know that there's a lot of waste that's involved with this, not to mention just the emissions. So being very mindful of age-related screening recommendations, choosing wisely, and the Center for Effective Practice are all great resources for guidelines. Cancer Care Ontario is another one. And even something as simple, which I've started to do, is providing a really good history for the radiologist for when you're ordering imaging. So really pinpointing like what you're trying to rule out. And I've started to ask radiologists for recommendations about interval testing and whether we can maybe extend, for example, if we're monitoring something. With patients, I do try to give them some education around you know, uh, the exposure to radiation is not insignificant. So, for example, a typical chest CT is equivalent to 3 years of normal background radiation and 10 days for a chest X-ray. So, I do try to tell patients, like, if you're not presenting with symptoms that require imaging at the moment, it's really I just can't justify exposing you to this radiation. And generally, patients are pretty good about this. And then I also try to, really refer to physio a lot, get physio's take on whether they think imaging would be important, ask my colleagues who are much more experienced in MSK issues, for example, what's the best modality, whether they need it. Ultrasound is a really good option for a lot of joints, and sometimes can be more than enough, and we don't need to go on to an MRI, for example. Okay, so we've covered all this. So one of the other principles for sustainable healthcare is empowering patients. So I'm not going to go into this too much. This is our bread and butter as nurses. We have, we focus, we our patients. They are the center of their care. And why this is important from a planetary health lens is that when we really get to understand our patients' goals and what matters to them in terms of treatment, we can avoid unnecessary care if they never wanted it in the first place. And if they're not interested in a workup or treatment, but they maybe don't have all the information or they feel pressured to go through some of these. So the Sustainable Primary Healthcare Toolkit has amazing resources about this, just for general practice. I really encourage all of you to look at it. Health promotion, again, this is what we do best as nurses. This is where we really see the health, social, and environmental co-benefits. So, and if we can keep our patients' care on like in the primary healthcare realm and in prevention, it's significantly less than an intensive inpatient stay in terms of emissions, up to 120 times less CO2 equivalent emissions from, primary care to an inpatient stay. So, these are pretty self-explanatory. Social prescriptions, getting people out into nature, getting them around other people, plant-rich diets, even one meatless meal per week is one of the most significant things that you can do for the planet. And then we know that there are the co-benefits to our patients in terms of decreased risk for diabetes, obesity, cardiovascular disease, colorectal cancer, exercise and active transport. This decreases the emissions to and from healthcare appointments. Tobacco and alcohol have an environmental footprint, so if patients need a little bit more incentive, this is a good one. Secondary prevention, again, just keeping patients out of the hospital as much as we can. So lastly, the environmental alternatives. June covered this so well with the inhalers. Um, I won't go into it too much, but I will tell you that this is the chart that I use. So most of my patients, just being military members, they don't have very complicated respiratory profiles. So I have a handful of patients who are on Ventolin inhalers, just as needed, with a documented history of asthma. And what I have started to just switch them over to is this Bricanyl Turbuhaler. Uh, it's been a very straightforward switch. So what I've done when the patients come for a renewal, I just say to them, like, it's my practice now to prescribe lower emission inhalers. And did you know that your Ventolin inhaler is basically equivalent to driving almost 300 kilometers in a car? If we switch you over to this Bricanyl one, which is equivalent, um, just as easy to use, and it's covered by insurance, it can be the equivalent of 6 or 7 kilometers. And I find like most people are totally all in for this, and they're very surprised to learn that their Ventolin inhalers have been very, you know, bad for the environment. So, and I've had very good feedback about the Bricanyl, so that's been a very easy switch for me. Okay, what else here? Medications. I should say about inhalers too. I have a very low threshold for sending people for pulmonary function testing, just to really determine, as June said, whether they even need the inhaler. And I also have to do quite a lot of education around there's no evidence for inhalers for post-viral coughs. I actually get that question quite a bit. In terms of medication, shorter trials for new medications, so we're not stuck with like 3 months of meds for, a medication the patients can't tolerate the side effects, for example. We can promote pill splitting. So this decreases the producing, packaging, and shipping, for example. Shorter duration of prescriptions for PPIs and NSAIDs, for example. Oral instead of parenteral medications is better for the environment. I love the example of long-acting reversible contraceptives because this is not only beneficial for the patient in most cases, but it decreases the environmental footprint because, 3 years with an Nexplanon insert, for example, compared to 5 to 8 years with an IUD in terms of packaging compared to all that time on a pill, for example. And then also, many women achieve amenorrhea within the first year or two um, on the larks. And so that is, beneficial for them if that's what they're looking for. And it also decreases all of those years of the waste of feminine hygiene products. So virtual care is a great option. And then clinic operations, so eliminating unnecessary products. Katie really covered this very well. In my practice, I do try to make little changes. Like I learned that sterile gloves have a higher environmental footprint than non-sterile gloves, and we no longer need them for things like IUDs or other office procedures. So I just use regular gloves for IUDs. And unfortunately, my workplace is, we don't have an autoclave, so everything is disposable and single use. So just trying to cut down when I can. So for example, for IUDs, I no longer use the prepackaged IUD kits. There was so much waste. I just use I bring in whatever I think I need in terms of equipment, but single packaging so that if I don't use them, I can just put them back. Uh, okay, so lastly,
Cailin, I'm just going
yeah,
to jump in really quickly and say, so we've reached the hour, which is
okay,
totally fine. Just if anyone needs to go and has other commitments, no worries. Thank you for joining. We will let Cailin finish off here, and then Katie and June, Cailin, are you guys good to stay a little late and answer questions?
Yes.
Yeah.
Yep.
Okay, awesome. Thank you. Okay, so then I'll let Cailin wrap up and we will carry through with the Q&A again.
okay.
Thank you to those who
Sorry.
have joined and you to no, don't be sorry. It's
I knew
totally
I'd go
fine.
over. I'm so sorry.
No, don't
Uh,
even worry about it. But yeah, this presentation is recording, so even if you guys want to ask some questions before you jump off, the panelists will answer them and you'll get those answers in the recordings. So yeah, okay. Finish up, Cailin.
Okay, so this is just I really like this resource. This is the Social Tipping Interventions by Dr. Howard, Dr. Courtney Howard. So I use this one to kind of ground myself in some of the changes that I'm making. So we can see that there's like micro, meso, and macro level. Micro is the individual pro climate change, meso is more institutional, and macro is the big subnational, national, international projects, right? So you can see I've been really just trying to make changes in this micro kind of sphere here, just me and my patients and like my own my own uh exam room, for example. I'm trying to push it up into more of like the meso and try to get more people involved and spread it across the clinics. One of the my pet project right now is trying to ditch the exam table paper. So we still use it on all of our exam tables. And there's really no evidence whatsoever that it's helpful or that it decreases infection. So I am trying to move this beyond just my own little exam room. I have been invited by our manager to join the Environmental Health and Safety Committee to present this as an option for the entire clinic. The other thing that I've been doing is making posters like this one, and I send them out to all of my colleagues, to the entire clinic. I try to coincide with Earth Day and the National Day of Action on Planetary Health, for example, and just kind of try to bring people in. These are just, lastly, some resources and some forums where you're more than welcome to join if you've got some ideas about sustainability, you're not sure how to implement them in your practice. The Greening Nursing School of Community of Practice with Ontario Nurses for the Environment. This is how to reach us at Ontario Nurses for the Environment if you'd like to join us. CANE and ONE meetups, and then Cascades. This one looks great. I haven't been able to attend it, but I've joined Echoes for other issues, and it's been invaluable. So this is important too if you're interested. Key messages. I mean, yeah, just hope is action, change is possible. Get involved if you can. So that is my just some more resources here. That is my presentation.
Awesome. Thanks so much, Kaylin. And thanks to those who have stuck around. Please feel free to add some questions into the chat or Q&A for any of our panelists. Um, June, I see you answered some of the questions that came in the Q&A, but maybe we could quickly speak to those aloud for anyone else's reference. So I know Rob here had a question about pharmacy disposal actually lessening GHG emissions, particularly related to the inhalers. So do you want to share what you sent to Rob about that?
I think I did reflect that in the life cycle that all the inhalers are still really bad at the end of life. You know, we're getting rid of that plastic, and I really took notice of what Katie was talking about, bioplastics, etc. If we could encourage, and I think that's, Rob, as you know, we've got power. We do, if we can get together, we can influence these industries, etc. And it could be maybe a little bit of greenwashing at this point, because they do say the high fluorocarbon gases are destroyed by the incineration, but yes, then what? Look what happens after that. And we know that the plastics, they say they may be recycled, the aluminum may be recycled, but we know healthcare products are not recycled very well. So that really needs to improve. And again, if we could bring our voices together, I think we could influence the industries to do that. And we could choose ones that maybe use bioplastics in the inhaler production and so forth. So I hope that answers that question. I totally agree that we have so far to go. And then someone else asked about the cost differentials. I'm not sure how current my costs are here, but this kind of gives you an equivalent if you look at it proportionally, that a rescue MDI is about $20, a controller is about 40 to 100, DPI is about 45 to 200, SMI is about 70 to 90, and Cailin might have some more insight into that if those are accurate or not for the SMIs and DPIs. But the thing
Yeah, I
is
don't know about the
coverage, isn't it?
cost, but
Yeah,
yeah, for us, we're lucky in that Blue Cross for our military members is actually it does cover a lot of the DPI. So
yeah.
we're lucky in that sense. But that's not the case for everyone. So that is an important consideration.
Yeah, that is, and I know there are initiatives being done like by CAPI, Canadian Association of Pharmacists for the Environment, on trying to make that more equitable, to make it more covered, etc., the alternatives. So I think that's probably the biggest issue. Will my plan cover this? And I hope I answered that sufficiently.
Yeah, I think that's great. Thanks so much, June. Thanks, Kaylin. Doesn't look like there's any more questions that have come up in the chat here. Oh,
Oh,
one more. My question is for the host of the program. Oh, me. Are we getting a certificate of participation? I don't, we don't usually do like certificates for being present in these. It does take in order to get credits and things like that, it's a long process. But we do appreciate everyone for joining us and for taking part in this. And I mean, it's definitely something that you can reference going forward, that you attended our webinars in this webinar. So thank you. Okay. Well, thank you everyone for joining today. Thank you, Kaylin, Katie, and June. Really appreciate your wonderful presentations. As I mentioned at the start, this was recorded. The recording will be sent to all registrants today, along with I have so many resources to share. All the presenters have, provided so many amazing resources that should be sent out to the registrants. So you can look forward to those coming your way as well. Kaylin, if you could actually share your slides with me so that I can pull some of those great resources out, that would be awesome. And so I can send people the link. So thanks,
absolutely. Yeah.
everyone. Have a great rest of your day and weekend.
Thank you, everybody.
Bye,
Bye.
everyone.
Thank you.
Take care.